These patients are typically actually identified in the postmortem setting on autopsy because they usually go into cardiac arrest. And then finally, just to briefly touch on type 4 and type 5, type 4 would be any type of complication that can occur after they have undergone PCI previously. So maybe they had been taken emergently to the cath lab and have restenosis of a previously placed um, stent. They can have dissection of the coronary artery, embolization from that site, or occlusion of a side branch. And type 5 is an acute MI within 48 hours of a coronary artery bypass graft surgery. So when we're talking about what we've traditionally called STEMI equivalents, what we're really trying to determine is if they have an occlusion MI. So this encompasses type 1 acute coronary syndrome. So essentially what you're looking for is total occlusion or near occlusion of the infarct-related coronary vessel, which would have insufficient collateral circulation, which means essentially that you're looking for lesions that could eventually lead to a full thickness infarction, unless the flow to that artery is restored. So these are the STEMI equivalents or occlusion myocardial infarctions that we'll be discussing today. Before I move on, are there any questions that anyone has right now that I can answer, or is everyone following along? Doing okay? Thumbs up? Okay.
Okay, you continue.
Okay. Um, So the first OMI that we'll discuss is the de-winter T waves. So these are typically located, you can see them in lead V3 or the precordial leads. But what you'll notice is that there's an ST depression at the J point, which goes into these tall symmetric T waves in each beat. So what you're looking for is an ST segment depression that's greater than 1 millimeter at the G point in the precordial leads. You will not see ST elevation with the de-winter T waves, and then you'll have this upsloping symmetric T wave. And what this is suggesting when you see this morphology is an occlusion of the left anterior descending artery. And you may see this morphology on your EKG just prior to a patient going into a full-blown STEMI. So this is a concerning morphology that you should be aware of. The next is Wallen syndrome. So this is more of a clinical syndrome. So if someone comes into the emergency department and is saying that they were having chest pain, that sounds pretty classic for acute coronary syndrome, such as crushing substernal chest pain that was ongoing and then resolved on its own, and they're now chest pain free. If you end up getting an EKG on this individual that has these morphologies on it, you should be concerned for Wallen syndrome. So what you would notice in the leads V2 and V3 is either a biphasic T wave that you're seeing over here on the first image, or a deeply inverted T wave in these leads. And what this is suggesting is a critical stenosis of the proximal left anterior descending artery. And these patients would want to go or would need to go urgently to the cath lab, and you would contact cardiology for these patients. The next is identifying a posterior myocardial infarction. Sometimes these are challenging to identify because you're not really looking for the classic ST elevation. So what you would be seeing in a posterior MI in leads V1 through V3 that you're seeing over here is a very horizontal looking ST depression. as well as upright T waves in these leads. So if you see, especially in leads V2 and V3, if you're seeing that ST depression, that should that should ring some bells that you should be concerned about a posterior MI. And oftentimes you'll see ST elevation in the leads 2, 3, and AVF for an inferior MI that's associated with the posterior MI. And this would suggest an occlusion of the left circumflex or the right coronary artery, depending on what branch is supplying the posterior aspect of the heart. The next OMI would be a right ventricular myocardial infarction. So this is all focused on V1, which is the only lead that looks directly at the right ventricle when you're performing a classic 12 lead EKG. So essentially what you're looking for is ST elevation in V1, which you see mildly over here, but not too much, but you will see an ST depression in lead V2 that's associated with this. And when you end up seeing that ST elevation in V1 with ST depression in V2, this is highly specific for right ventricular infarction. You would also see ST elevation in leads 2 and 3 associated with this, and oftentimes it'll be more prominent in lead 3, which you're seeing over here as well. You can also, if you're suspicious of a right ventricular infarction, but you're not entirely sure if that's what you're seeing, you can perform a right-sided EKG as well. So you would be looking at V3 through V6 on the right side, and you'll be able to kind of determine from there. But if you have enough clinical suspicion, you can always have cardiology see these patients as well. One thing to know with these patients is they are very sensitive to preload changes. So in these individuals, if you happen to give them nitroglycerin, you might bottom out their blood pressure and lead to severe hypotension. Versus any of the other myocardial infarctions that you encounter. So you really want to actually increase their preload to help with the blood flow in the heart. The next OMI is seeing ST elevation in lead AVR, along with diffuse ST depression throughout the rest of the EKG. So what this would be indicating to you is subendocardial ischemia due to a decrease in oxygen. So maybe the patient is severely hypoxic, or if there's not enough oxygen to meet the demand of the heart. So there's many different reasons that can lead to this morphology on EKG, which can include left mean coronary artery stenosis, proximal left anterior descending artery stenosis. If you have severe triple vessel disease, this can present this way on EKG. Or like I said, if you have hypoxia or hypotension and just, hypovolemia, it can lead to these changes as well. So this is what we're seeing. So you're seeing the elevation in AVR over here, and then you can see that diffuse ST depression throughout the rest of the EKG. The next is something that I feel can be easily looked over because the rest of the EKG looks pretty much normal. And that is a T-wave inversion that you're seeing in lead AVL. This is associated with both mid-LAD lesions that might become unstable or an impending inferior wall MI. And this can be correlated with a lesion in the right coronary artery, the left circumflex, or the left anterior descending. So it's pretty subtle. Located right over here, you're seeing that T-wave inversion. That's the one that's concerning, and that should prompt you to further evaluate the patient for acute coronary syndrome. The next is hyperacute T waves. This is one that we probably hear about, even in medical school. It's pretty prominent. So Here you would be seeing hyperacute T waves in at least two or more contiguous leads, which could be sometimes the first sign that there might be a developing STEMI in a patient. So, to get a better understanding of what that means, is over here you'll see hyperacute T waves. So, essentially, the QRS complex, the T wave is much larger than a QRS complex in comparison to a normal EKG morphology, where the length of the QRS complex is much larger than a T wave. And the suggested occlusion for seeing a hyperacute T wave is the left circumflex. And finally, to go over the Scarbosa criteria, this is to evaluate for possible STEMI in individuals who have a left bundle branch block present, whether it's new or something the patient has had for a while, and if they have a paced ventricular rhythm that you're seeing. So this is what a normal left bundle branch block or paced rhythm would look like over here. What you're looking for in these patients is a concordant ST elevation over 1 millimeter leads with a positive QRS complex. So what that's saying is when the QRS is going upwards, you would want to be seeing at least 1 millimeter of ST elevation over here, which would be concerning for a STEMI in these patients. You could also potentially see a concordant ST depression in over 1 millimeter in leads V1 through V3. So that's over here that you're seeing this. So the QRS is mostly going down over here. So you would see that ST depression. And then you can also see excessively discordant ST elevation over 5 millimeters in leads with a negative QRS complex. So this is a negative QRS complex that you're seeing over here, but this ST elevation over here is greater than 5 millimeters. So that can indicate to you that there might be something else going on underneath. So to move on to what has classically been called an NSTEMI or a non-occlusion MI, this is essentially any of the classifications from type 1 to type 5 that we discuss that does not satisfy the description of an occlusion MI. So the ones we just talked about, which would essentially include anything in type 1 where you're concerned for a total occlusion or near occlusion of the coronary vessel. And I'm sure we've all come across this in our clinical practice, but sometimes individuals can come in with a non-occlusion MI and they might not have any definitive changes that you're seeing on EKG. The EKG can look completely normal, but they might have an elevated troponin or other risk factors that would make you more concerned for these patients. Unstable angina is also something that we need to keep on our radar in the emergency department. So these individuals will have symptoms that are concerning for ischemia and acute coronary syndrome, such as chest pain, with or without changes on their EKG concerning for ischemia, but they always or most of the time tend to have a normal troponin level. So this is an acute coronary syndrome where patients typically do not have an elevated troponin, but they are having concerning symptoms to you. So it's characterized as angina that is either new in onset, is occurring at rest or with minimal activity, or is otherwise worsening from a previously stable pattern. So, for example, stable angina would be you start exerting yourself, and because of that increased demand on the heart, you start having chest pain, but at rest, it goes away. Whereas with unstable angina at rest, it can still continue because of that spasm of the coronary arteries. And like I said, you don't always see EKG changes on these individuals, but you might if you happen to catch them at the time that the spasm is occurring, and they typically have a normal troponin level. So before moving on to the ACS scoring systems, I see that we have some messages. Just wanted to take a look.
Yeah, Juliet answered the
Oh,
question.
okay, perfect. Okay, perfect. Okay. So the ACS scoring systems that can be used in the emergency department, the big one that we are probably most familiar with is the heart score. This is the one that I would use the most in the emergency department. There's also a few others that are notable that could be used. They're more involved, so I don't typically use them, but those include the TIMI score for STEMI, for unstable angina and NSTEMI, as well as the GRACE score for ACS risk. So the heart score over here takes into account multiple categories. So the first is the history of the patient. So is the story that they're telling you concerning for acute coronary syndrome? Is it highly suspicious, moderately suspicious, slightly or non-suspicious? I know we had kind of touched on this last week in terms of how do you know if they should be rated as highly suspicious or moderately suspicious. And this is kind of the part that sound is more subjective in the heart score. Then you look at the EKG, if there's any changes that are concerning to you and rate them based on that. Their age will give them varying points, risk factors for coronary artery disease, which are listed at the bottom over there. So things such as diabetes, smoking, high blood pressure, dyslipidemia, if they have a family history of coronary artery disease, which is always important to ask in these patients, and depending on if they're obese. And then finally, the troponin level, if it's normal, if it's greater than normal, and what level they're at with that. So essentially what the heart score is telling you or trying to guide you towards is if the patient has a low score with the heart score, then this patient might be adequate to be discharged home. And it tells you kind of the risk of major adverse cardiac event in these patients. So for example, if you score 0 to 3, you have a 2.5% risk for major adverse cardiac event over the next 6 weeks. If you have a score of 4 to 6, then that goes up greatly to 20.3. And then finally, if you're scoring 7 to 10, you have a greater than 70% chance of a major adverse cardiac event over the next 6 weeks. So you do want to prioritize getting these patients in for early invasive procedures if possible. The next is the TIMI score. So essentially what this is doing, the TIMI score for STEMI is assessing for the risk of mortality from having a STEMI in patients who have varying risk factors. So in this case, you're looking at the patient's age. You're looking at what their systolic blood pressure is when they come into the emergency department, their heart rate, whether or not they have anterior ST elevation or left bundle branch block, their risk factors, what their weight is, and then time to treatment. And then you're looking at something called the kilo class, which is listed over here. So this is the risk of developing heart failure, or if they have any heart failure symptoms that are new for them, that may contribute to their mortality risk. So as you can see, this is much more involved. This is more so something that cardiology might use inpatient, but it can still give you valuable information if the patient is presenting as more critical in the emergency department. The TIMI score for unstable angina and NSTEMI is predictive of the severity of the vascular disease that the patient may have, depending on the score that the patient receives. And this is predicting the patient's risk for death and other ischemic events in the future. So it's taking into account similar aspects to the TIMI score for STEMI, such as age, risk factors for coronary artery disease, takes into account if the patient is on aspirin currently, if they have known coronary artery disease, if they've had any angina symptoms at rest, if they have any changes to their EKG with their ST segments, or if they have any elevated troponin level. And then it's categorized if you get a score of 0 to 2, you're low risk. If it's 3 to 4, intermediate risk, and then high risk is 5 to 7. And then finally, the GRACE score for acute coronary syndrome is a tool that estimates the probability of death in patients with acute coronary syndrome from admission to the hospital to 6 months following discharge. So again, this is one that you might not necessarily use in the emergency department, but I just wanted to be complete with what we can use. Of course, there's a lot more involved with this. So even in terms of time and efficiency, you wouldn't necessarily have this, but there's always the calculators online that are available for your use if you're interested. Okay. Are there any questions that I can answer right now? Has anyone seen any of those EKG morphologies that we've talked about in their practice, such as Wellens syndrome or posterior MI? Did any of those look familiar?
Yeah. Okay. So for me, I usually saw the see the patient have the STEMI, uh, almost every day, and
Oh, I
yeah we usually use the TIMI score for the patient.
okay.
Yeah, and we in our emergency center we will connect to the cardiologist and we have the patient, we will stable uh, do something for stable patient, give
Mhm.
medication, and contact to the cardiac and send the patient.
How
Oh,
fast are you able to get the patient to the cath lab after you call cardiology? He might be frozen.
does it? I have a question for our doctors practicing in Vietnam. Does your hospital have a time limit as to when you diagnose the STEMI to either thrombolysis or balloon time? Because we in the US, um, they will measure us and, you know, give us bad news if we don't meet a certain timeline.
Uh, okay, yeah. Actually, we have in like my hospital, we when we have the patient with coronary infection. So we also use the 120 minutes the time patient. So we are the top in the hospital. So uh, a lot of patients when they send to our hospital is the have the overtime.
Okay.
Any other thoughts from anyone? Okay. All right. So we're going to move on to the case study portion of the lecture. So this is going to be similar to what we did last week. So We'll need a lot of participation from everyone that's here today, asking questions, what they would want to know from the patient, and what they would be doing for this patient if they came into your emergency department. So the patient we have here today is a 37-year-old male who's coming in with chest pain. So what questions would we want to ask this patient? Hung, let's start with you. What would you want to know?
Uh, I want I want to ask him how long and what's the um, how how he feel with the child.
Okay, like what the quality of the chest pain is.
Mm,
Trin, what would you want to know from this patient?
Yeah, with the patients, I want to know first either the locations of the pain. Yeah, the pain are more on how on one location when it's pain and what time the how long is starting or and some symptom with the chest pain. Like dyspnea or something like that. Yep.
Okay. Hui, how about you? What would you want to know?
Uh, I want to know there anything make the pain better or worse? Have the patient had this pain before? Any associated symptom?
Okay,
Uh, thank you.
great questions. So this patient is a 37-year-old male. He has a history of tobacco use, crack cocaine use, alcohol abuse, hypertension. He came in with chest pain. It began 2 hours ago after smoking cocaine. The pain is located in his left chest and is accompanied by left arm tingling. There's no radiation of the pain to his back, so there's no ripping or tearing pain to the back, no associated arm pain or jaw pain. The pain is associated with shortness of breath and sweating, no nausea or vomiting, no feeling lightheaded or dizzy. So, in your initial assessment of the patient, what would you be doing for the patient? So, this is right when they come into the emergency department. What are some actions that we would be taking right away to evaluate the patient? The first step every time you see a patient in the emergency department.
Yes, A B C D.
Good. Yep. Okay, perfect. So you do your primary survey, which includes the ABCDE as well as the vital signs. So in terms of airway, the patient is speaking in full sentences. Breathing, they're in no apparent respiratory distress. There's no cyanosis that you're noting. Circulation, they have normal capillary refill. They are tachycardic. Disability, their GCS is 15. They're answering questions appropriately. And then exposure, there's no bleeding or rashes that you're noticing. In terms of their initial vital signs, their blood pressure is 143 over 69, heart rate of 100, respiratory rate of 20. Their temperature is 35.7, and they have an oxygen saturation of 99% on room air. And when you look at the patient is agitated and they look uncomfortable. So what actions would we want to perform for and on the patient now? So you've done your primary survey, you've gotten kind of your initial evaluation done, and you have some preliminary information. What would you be wanting to do now? Let's see. Nia, what would you do? What would you want to do now?
So I will take the patient on the monitor and also put an IV and check the ECG and full code.
Good. Perfect. So you can put the patient on oxygen for comfort. This patient is not really hypoxic, so you don't necessarily have to. You would want to get your peripheral IV that you noted. You can start working on labs at this point, put them on the monitor, get an EKG. You can consider putting the defibrillation pads on them, depending on what they look like, if you think they're stable versus non-stable. And then as we discussed last week, all of these actions can be occurring simultaneously, so you don't have to wait until you're done your primary survey in order for these to start going as well. So more history from the patient. What are some things that you would want to know? Yeah, I'll give you this one. So you would want to know their past medical history. So this patient has a past medical history of hypertension, any surgeries they've had in the past. This patient has not had any surgeries, any allergies they might have. There's none here. Medications they might be using on a daily basis. This patient does not have any daily medications. Their social history is always really important, and especially in this patient. So they smoke cigarettes, they use crack cocaine, and they have alcohol abuse. So they're using alcohol on a daily basis. So lots of risk factors from that perspective. And then family history, they don't have any family members that have a history of premature cardiac death, coronary artery disease, or myocardial infarction. So for your focused physical exam, what are some things that you might be looking for? Trin, not popcorn, other Trin. What might you want to be looking for on your physical exam?
I checked his pulmonary check. Um,
Good. Anything else you would want to look at?
please, yeah. Please to a concentration bilateral equals and symmetric chest rise. Chest normal rise and breathe normal heart sounds.
Good. Kong, anything else that you would want to look for on your physical exam?
I think we will focus on the chest and heart examination. To
Okay.
yeah.
Okay. All right. So you do want to look at the heart and the chest. We also want to make sure that we're looking, of course, at the general appearance of the patient. Depending on what you're concerned about, you also want to do a neuro exam on these patients. You know, if there's any concern for aortic dissection, which you could have in patients with cocaine use or high blood pressure. And then their skin, their abdomen sometimes can give you some indications, as well as what their extremities look like. So this patient on general appearance looks slightly agitated and uncomfortable due to the chest pain that he's experiencing. No abnormalities on his HEENT exam as well as his neck. He does have normal breath sounds. He does not look like he's in any respiratory distress. He's not having any tenderness to palpation over his chest wall. In terms of his heart exam, he is tachycardic, but it's a regular rhythm. He does not have any murmurs. He does not have any distal heart sounds. A non-tender abdomen. There's no masses, no pulsatile mass or anything that you're seeing. There's no distension of the abdomen or fluid wave. His extremities, not seeing any cyanosis. There's no peripheral edema that we're seeing. And then neurologic. Motor function is intact, upper and lower extremities. His cessation is intact of his upper and lower extremities, and he has a normal gait. And then skin, he's slightly diaphoretic, so he's sweaty. So, what are some things that would be on your differential diagnosis at this point in your evaluation? Hui, what would you be thinking right now?
Um,
What might be causing his chest pain?
uh, some different diagnosis is acute coronary syndrome, pulmonary embolism, aortic dilation, um, tension pneumothorax,
Okay. Anything
uh,
else that oh, yeah, go ahead.
cardiac tamponade. Uh,
Perfect. Yeah. So, at this point, we have the history of him using the cocaine use and having his chest pain start, but want to still kind of keep a broad differential to make sure that we're not ruling anything out without doing the appropriate testing. So, like you said, it could be acute coronary syndrome, it could be vasospasm from the cocaine, aortic dissection. We still have all the other differentials that we discussed last week that remain there. Maybe less likely to be causing his chest pain just given his clinical presentation, but always want to make sure that we're still considering them. So, at this point, what labs would we want to get on this patient? What medications we might use for the patient? And what imaging would we like to do? Nia, you seem ready. What would you want to do?
Oh, okay. So I will perform a roll blood cell. So it's liver, kidney function, and D or the eye hypersensitive. So, of course, I have to see the ECT of this patient and the chest X-ray. Finally, is uh, cocaine in urine. Yeah, so toxic for test. Yeah,
Yep,
and
it's a good thought.
finally,
Good.
maybe I will perform the cardiac ultrasound if it's not normal in yeah.
Okay. Then I don't know if you said it, but we would want to get a troponin on this patient. I might have missed that. You might have said it. And we always want to do our point of care ultrasound, right? Because we're in the emergency department.
Yeah.
Yeah. Good. Okay. So, essentially what you said, so looking at the complete blood count of the patient, complete metabolic panel, coagulation studies, troponin. If we are concerned about a pulmonary embolism, we can get the D-dimer, urine drug screen, like you said, point of care ultrasound to take a look at the heart and potentially the lungs as well, and then the EKG chest X-ray. And then things that we didn't touch on would be medications that you could give this patient in particular. So, um, like the clinical picture initially was saying, the patient is agitated, they're tachycardic, they're sweaty, which could all be related to the cocaine use. So you can consider using a benzodiazepine for these patients to try and calm them down, which can sometimes help with those peripheral symptoms, but also, help their heart. Consider giving this patient aspirin, morphine for pain control, and we could consider nitroglycerin as well. So this is the patient's EKG that we're seeing over here. So it looks maybe normal sinus, maybe slightly tachycardic. There's PVCs over here. maybe some peak T waves that we're seeing, but otherwise doesn't look too bad. And then this is the chest x-ray of the patient. Pretty much clear lung fields over here. There's no really widening of the mediastinum. You can still see the aortic bulb. There's no blunting of the costophrenic recess or anything to suggest fluid there. So it looks pretty much normal as well. These are the lab results of the patient. Does anyone want to go through them quickly and just see if there's anything that's sticking out to them at all? Hung, anything that's sticking out to you with the blood work?
I think we can try troponin hypertensive.
Sorry, I missed that. Could you repeat what you just said?
We try that troponin hypertensive.
The troponin? Yeah, so the troponin is down over here. It's normal, which is good. The D-dimer that we got is normal. Everything is essentially looking okay. Um, he actually has slightly elevated lipase and amylase over here, but he's not having any abdominal pain and no nausea, vomiting. So things are things are not looking too bad from the blood work perspective. So after you give the patient the medications, he appears less agitated. He looks more comfortable. His vital signs also look improved. His blood pressure is 108 over 81, heart rate of 85, respiratory rate of 16. And we did put him on supplemental oxygen just for comfort initially, but he still is satting appropriately. So finally, the disposition for this patient. Typically, you would want to admit this patient to the observation unit so that you can risk stratify them for acute coronary syndrome because they do have a number of risk factors. If they happen to improve in the emergency department, and you watch them for several hours, then they would just depending on, how they're scoring and what they look like, you would want to have close follow-up as well. So just to go over quickly before we move on to some questions, this patient came in with chest pain following cocaine abuse. The patient's symptoms of chest pain were likely related to cocaine-induced vasoconstriction of the coronary arteries, like we discussed on our differential. So things that were important to do early on included an EKG, which we got, giving the patient nitroglycerin and morphine for pain control, giving aspirin, giving benzodiazepines to control that tachycardia and that hypertension. And then if we had not given the benzodiazepines, we would have seen that the patient would get more tachycardic, more hypertensive as well, which could potentially propagate their chest pain getting worse. And then we got the chest x-ray, which is good because we do also want to look at other pulmonary factors that could be contributing to the chest pain from the cocaine use. And then, like I mentioned, if the patient is sent home without the full MI workup, they should return to the emergency department immediately if they start having worsening symptoms or if they come back. And then just briefly, this is saying that we want to be looking at etiologies for chest pain in patients with cocaine use that is both from the cardiac perspective, but also pulmonary. And then benzodiazepine use is also really important in their treatment. One thing that I did want to touch on is that typically beta blockers have been avoided in patients with cocaine because of the fear that it's going to lead to unopposed alpha adrenergic stimulation, which could make their symptoms a lot worse. There has been literature in recent years that kind of goes against this and says that beta blockers can be used in this patient. I think it's really your personal preference at this point, because people kind of go both ways on this. But that is all for the case study. Does anyone have any questions regarding the case study?
Compare nitrate with the morphine for chest pain. Compare nitrate with morphine for chest pain.
I'm sorry, you cut out for me just one more time. You can type it too if you would like. Yeah. While Hung is typing, we'll move on to our practice questions so that hopefully we can get through all three this week. So question number one, I am going to have, let's see. Who is still here? Okay. We'll have Hui answer this one. So this patient has a large anteroseptal myocardial infarction. Which of the following vessels is most likely to be occluded in this patient?
I think the answer is A.
Did you say A?
Yeah.
Okay. All right, let's see. So the answer is actually B, the left anterior descending artery, because this is in the anteroseptal area of the heart. So that's where the left anterior descending artery supplies. And then just as a reminder of what we had looked at earlier, so anteroseptal distribution over here, which is where we were seeing that elevation, V1 through V4 is supplied by the left anterior descending artery. Then next, we'll have Kong answer this one. So a 63-year-old male presents with chest pain radiating to his back. Vital signs are a heart rate of 123, blood pressure of 123 over 104, and oxygen saturation of 95% on room air. A chest x-ray is shown above. What therapy should be immediately initiated in this patient? So the first part would be, what do you see in this chest x-ray that is concerning to you? And you can talk it through out loud as well, if that helps. Hong, any thoughts?
I think C.
C? Okay. What are you thinking this is before we check the answer?
So I saw the left the lower left lung not clear, and yeah,
Okay. All right.
the symptom is yeah. I'm considered that the patient have the pulmonary edema.
Pulmonary edema. Okay, so we were thinking maybe there's some pulmonary vascular congestion that we're seeing on the chest X-ray. Okay, so the answer is actually A, Esmolol. And the reason for that is what we're seeing over here is widening of the mediastinum over here, as well as blunting of that aortic bulb. So what we would be concerned about in this patient who has that chest pain that's going to his back, he's tachycardic and hypertensive, is that he might have an aortic dissection. So the reasoning for the Esmolol would be to try and both decrease his blood pressure, but more importantly, decrease that heart rate to prevent that shearing force. And then finally, question 3, we'll have Popcorn answer this one. So, a 54-year-old man with diabetes and a long smoking history comes to the emergency department with chest pain associated with exertion over the past day. He suddenly becomes pale and diaphoretic. He reports pain over the anterior chest and trouble breathing. The above EKG is performed. Which of the following is the most appropriate step in management? Oh, looks like Popcorn's busy with work. Mia, what do you think?
So what is the blood pressure of this person?
I'm sorry?
What is the blood pressure of this person?
The blood pressure? So we have to
Yeah, yeah.
answer. This is all the information that we have for this patient. So we have to answer
Yeah,
with this
okay.
information.
So if the blood pressure is normal, I will to the I will to B. Yeah.
D? Okay. All right.
Yeah, okay.
Well, you're right. Good job. Yeah, so I think what you were thinking with the blood pressure is that you wanted to know if the patient was stable or unstable. Is that kind of what you were
Yeah, yeah,
thinking?
yeah,
Yeah,
okay.
okay. Yeah, so that's a good thought. Other ways to know if patient is unstable is if, their clinical picture. So this patient became pale and diaphoretic all of a sudden. If they're having any altered mentation, this patient was having trouble breathing, so he became symptomatic. That would lead you more towards the synchronized cardioversion. And then the rhythm that he was in was VTAC. And then this is the management of it. So you would be looking for the regular rhythm with a rate over 100 with the wide QRS complexes, which we were seeing. Um, this is kind of what it's talking about. The patient has a pulse and is talking, but has other signs of impaired function with his ischemic chest pain and his dyspnea. So that would kind of make you more towards the synchronized cardioversion because he's symptomatic and presenting as unstable in association with the VTAC. All right. Any questions? Looks like there's one in the chat.
They answered some of as a
Okay,
message. So
cool. Thank you.
all right. Well,
Okay,
thank you
perfect.
everyone for being here this week. We'll see you next week.
Yeah. Okay, thank you, everyone. We'll see you next
Okay,
week.
thank you for your
Yeah.
interesting presentation and
Recording stopped.
Yeah, thank you for being here.
yeah.
Bye, everyone.